states a multidisciplinary approach. You cannot treat any complicated intra-abdominal infection without a multidisciplinary approach. And the intensivist, the surgeon, the radiologist, the infectious disease specialist, and the microbiologist are usually involved. Coming to the etiology or classification, they are basically classified as 4 types. One is arising from the hepatobiliary system, 2 a hollow viscous, retroperitoneal, and 4 is pelvis. Coming to decision making, in any complicated illness, we need to make decisions. And the following best describes why an intra-abdominal infection would be considered to be severe or complex. 1, it is difficult to treat due to multi-drug resistant organisms. 2, it always requires a complex surgical procedure. And 3, it extends beyond the organ that is the site of origin. So let's make a working definition from all this, and that is that complicated intra-abdominal infection is defined as one that originates from a leak in the gastrointestinal tract and extends beyond the hollow viscous of origin into the peritoneal space. Although complicated intra-abdominal infections may be polymicrobial and may require complex surgical procedures, this is not always the case. A complex intra-abdominal infection can either be community acquired or healthcare acquired, and not only healthcare acquired as is believed by many people. Okay, so let's look at something that we feel is not a complicated or is an uncomplicated intra-abdominal infection but may not necessarily be so, and that is an intraperitoneal abscess. The period of morbidity is unusually prolonged in patients with intraperitoneal abscesses. The average hospital stay is 21 to 47 days. The presence of residual recurrent infection caused by inadequate surgical drainage, more common in patients with multiple or bilateral abscesses, is associated with significantly greater mortality. So here is a CT scan showing you a perforated viscous and a well-localized abscess. Now this looks like something that can be treated very easily just with the percutaneous drainage, but many times it doesn't happen because of the characteristic of the abscess or because of leak from or because of the technique. So what are the interventions that can be done whenever there is a complicated intra-abdominal infection? The general requirements for CT guided or ultrasonography guided percutaneous catheter drainage include 1, an abscess that can be approached adequately via a safe percutaneous route and is unilocular, not vascular, without and in the absence of coagulopathy. A liver abscess or an amoebic liver abscess, like Dr. Shenoy mentioned, is an example of this. 2, joint radiologic and surgical evaluation with surgical backup for any complication or failure. And 3, the possibility of dependent drainage through the percutaneously placed catheter. Failure may occur because of undrained abscesses or pus which is too viscid or thick to be drained via the catheter. Reports indicate that the morbidity and mortality associated with percutaneous drainage may be lower than with surgical treatment in certain defined situations. So percutaneous drainage for localized intra-abdominal fluid collections. With advanced technology, advanced imaging, etc., percutaneous localized drainage is becoming more and more common and widely used, even in peripheral centers. The overall initial success rate is about 80 to 90%. The complication rate is about 0 to 7%. Many unsuccessful initial drainage procedures can be salvaged by a second percutaneous drainage procedure. Operative management is needed in less than 5% of patients who can be adequately managed by a percutaneous drainage procedure. What about the duration of antibiotics in difficult source control? However, there are several situations in which a longer course of antibiotic therapy is appropriate. 1, for patients in whom source control is known to be suboptimal. The optimal duration of antibiotic treatment is uncertain and decisions on treatment duration must be made on case by case basis. You cannot go by statistics. In some cases, an indwelling catheter is required for ongoing drainage and removal of the infected material. We generally continue antibiotics in such cases until the efficacy of catheter drainage is established. For example, until an infected hematoma is liquefied well enough to drain effectively via the catheter. This may require 2 to 3 weeks for a peritoneal abscess. A liver abscess is usually or typically treated for 4 to 6 weeks. If there is chronic active drainage through the catheter from an ongoing bowel or biliary leak without accumulation in the peritoneal cavity, discontinuation of antibiotics is usually reasonable as long as the patient has clinically improved. But after stopping the antibiotics, if the patient condition becomes bad or worsens, you may have to restart the antibiotics. So the take-home message or learning point: localized abscesses or collections can be treated with percutaneous techniques, and if adequate source control is achieved, antimicrobial therapy can be as short as 4 days. What is the role of antibiotics in acute pancreatitis? The recommendations are that antibiotics should be given for an extrapancreatic infection such as cholangitis, catheter-acquired infections, bacteremia, urinary infections, pneumonia. Routine use of prophylactic antibiotics in patients with severe acute pancreatitis is not recommended. The use of antibiotics in patients with sterile necrosis to prevent the development of infected necrosis is not recommended. Infected necrosis should be considered in patients with pancreatic or extrapancreatic necrosis who deteriorate or fail to improve after 7 to 10 days of hospitalization. In these patients, either 1. Initial CT guided fine needle aspiration for gram stain and culture to guide use of appropriate antibiotics, or 2. The empiric use of antibiotics after obtaining necessary cultures for infectious agents without a CT guided fine needle aspiration should be given. In patients with infected necrosis, antibiotics known to penetrate the pancreatic necrosis such as carbapenems, quinolones, metronidazole may be useful in delaying or sometimes totally avoiding intervention, thus decreasing the morbidity and mortality. Routine administration of antifungal agents along with prophylactic or therapeutic antibiotics is not recommended. So in conclusion, a minimally invasive step-up approach as compared with open necrosectomy reduces the rate of the composite endpoint of major complications or death among patients with necrotizing pancreatitis and infected necrotic tissue. So let's summarize. In summary, source control is still integral to the treatment of most patients with intra-abdominal infections, even though approaches and techniques are being modified. Selection of empiric antimicrobial therapy for patients with intra-abdominal infection needs to be based on an assessment of patient risk and potential for resistant pathogens. And the duration of antimicrobial therapy can be significantly shortened. The recommended duration is 4 days. Thank you very much.